Dallas, we made it. All right, so we're gonna have a conversation today. I'm not gonna lecture at you for 2.5 hours, although I can. But I really want to engage you in this and be here in the room with you, and I want you to walk out of here getting what you want from today. Any bingo players in the audience? No bingo players in Dallas? Okay. So at certain times I may ask you to speak, to scream, to yell, to sing. Just go with it, trust me. At the end, we make a little YouTube mannequin video that's going around. But I'm here for you, okay? I got 2 hours, or as long as you guys want, or if you get up and leave and there's no one else in the room, I'll stop. But I really want you to get out of this today something that you could leave and start working on immediately. Before I do start of what I'm going to talk about, because I don't really have a plan here, okay? Don't be worried, I'm not a pilot. But I'll go in whatever direction you want. If you have a question at the time, raise your hand, call it out, I'll answer it. You're not going to throw me off. If you throw me off, it'll be more entertaining for you. Before I do start, are there any specific questions, some things that you guys want to leave here today talking about or knowing about?
Did you have to turn off the screen up there?
Do I have to turn it off?
The screen up there, can you turn that off? It shows on your face, it's disconcerting.
You could possibly turn that off. No, we can't possibly turn it off? All right, hold on, let's try. Listen to my voice. You don't want to look at my face anyway. Sorry about that. But some of these things I'm going to show you some video, but I'll stand over here if that helps, and I'll move around a little bit. Anything in particular about PF that you guys want to know?
I just want to know, as far as exercise goes, I know you probably get it, but no one's ever told me whether it's okay to push myself, not push myself, or, what's the limit as to the...
Perfect. I've done that a couple of times. So, what else? And we're going to talk not just about rehab, we're not just going to talk about exercise, we're going to talk about the whole kit and caboodle, the whole living well with pulmonary fibrosis. Other questions? Topics you want to cover? Diet, yes.
How to protect against the season of sneezing and
The sneezing of sneezing. Yes. What else?
Follow on after rehab.
What to do after rehab?
Yeah, how to keep yourself motivated.
All right. What else?
Keep yourself motivated.
Keep yourself motivated. Okay.
Oxygen levels.
Oxygen levels. Awesome.
Multiple prescriptions.
Multiple prescriptions. What else? All right, that's a good start. That's a lot of, yeah.
I see a lot of advertisements on TV for other dreaded diseases and all the progress that they're making, like Crohn's disease.
Right.
When do you think we'll get there with pulmonary fibrosis?
If I could answer that one, we'd be in a gold auditorium right now. But I'll talk a little bit about that. Okay, I'll talk a little bit about it. How to find a specialist.
I see a lot of advertisement. Doctors want to treat you using stem cell to take COPD.
We'll talk about that, yep. And what not to do. Basically right now, let me make that one simple and we'll get back to it. But if anyone's offering you stem cell, no one's there for lung disease in any. So I know what you're talking about. There's a certain institute that treats lungs, okay? Scam. And not only that, I don't know, I'll leave it at that, but another question. All right, I think we should start. All right, so here's the deal. Let me talk about a few things first. When you are diagnosed with IPF, okay? IPF is no joke. I don't have to tell you that, okay? It is no joke. If you do nothing, you will get worse quickly. You will die. Now, I don't want to start with something shocking, but let's start with this. None of us knows when we're going to die. I don't know when I'm going to die, okay? It could be this week, who knows, okay? So one thing that I hate, I would call it a pet peeve, but pet peeve is kind of like I hate when people cough near me. Sorry, that was just a coincidence. Okay. Sorry, but I would say pet peeve, but pet peeve is like I hate when people sneeze near me. No. But when I hear doctors, medical professions tell people how long they have to live, I hate that. Because the simple fact is we don't know, okay? But when I hear the story of people telling me about IPF, okay, what I hear is, I got a diagnosis, and I was told that I have between 2 months and 5 years to live, okay? Now, I'm gonna tell you a story, okay? Don't be insulted because it's about a dog. As most people know, I respect most dogs more than I respect most people. But I had a dog named Phoebe who was diagnosed with bladder cancer, okay? And the vet told me that she had 3 months to live. I was devastated by the news, and I basically did everything I could in terms of exercise, green tea, you name it. My dog lived 3 more years, but I'll be damned if every single day for those 3 years, I didn't think, was today the day, okay? And when a doctor or a medical professional or anybody or the internet, okay, tells you, guess what? The timer is now ticking, or the sand in the hourglass is now falling down, they do you a tremendous disservice, okay? Because the simple fact is, some people might have, oh my God, it's like you just got hit by a giant wave, and you have this idea like, well, why should I try? I'm gonna be dead in 2 months anyway, or 2 years, or 5 years. I mean, and especially IPF is something that often hits younger people. Okay, you don't have to be 80 to be diagnosed with IPF. And the other sad part about this is that IPF is often diagnosed years after the symptoms began, because you've gone through a workup for COPD and asthma and all these other things that would be like the horse that we think we hear, and IPF is the zebra. There's a saying that says when you hear hoofbeats, think of horses, not zebras, but almost nobody thinks of IPF first. So if you say to yourself, wow, this doctor told me I have 5 years from the date of diagnosis, and I was having symptoms, I'm diagnosed today, but I had symptoms 4 years ago, that's a problem, okay? So why am I telling you all this? Not to depress you. I'm telling you all this because what I'm trying to say is that IPF is no joke. It's huge. It's like the ocean. It's much bigger than you. It's much stronger than you. It never gets tired, which means that if you're going to be successful in fighting this disease, we better get ready to get our team together, to get our army together, to put all of our tools together, our weapons together, and fight like hell, okay? If I am in a shipwreck and I'm on a piece of plasterboard waiting here to see what happens, and I hate to use this analogy because I love sharks and I know that they would not harm, but there's sharks swimming around me. I know that scares most people, but it's a disservice to sharks. But the thing is, if I'm going down fighting. And that's, the fact that you guys are even here today tells me that you're willing to fight. Maybe you don't know all the weapons that are available to you. Maybe you don't know that you need to fight. But again, IPF is no joke. It's a big disease, and if you want to fight this, then you need to fight it on all fronts, okay? And by fighting it on all fronts, I'm talking about taking the right medications, having the right doctor, having the right medical team, exercising vigorously, okay? Eating right. Stress management is a very stressful, anxiety-provoking disease. Anyone who can't breathe, even for 30 seconds, knows that, okay? So, also prevention of infection, okay? All these things, they sound simple, and if I say to you, okay, make sure you wash your hands a lot, everybody knows it, but how many people are doing all these things every single day? So when I look at a patient and they come to me and say, is there anything we could do for you? And I say, well, what medicines are you taking? Are you exercising every day? What are you doing? Are you eating right? Are you at the right weight? Are you doing anything for stress management? And what are you doing about infection prevention? Because all these things on a daily basis, that's what it takes to move this car, okay? IPF is a fast-moving disease in a lot of different ways. And, as Dr. Wong said, the medicine is there now, okay? Some of the medicines are there. 15 years ago, there was absolutely nothing. So there's drugs out there, but don't expect the drugs to reverse the disease. The drugs are like, okay, the car's rolling downhill, the drugs are helping you to go down that hill slower. But the lifestyle stuff, okay, I'm telling you this because I believe it, the lifestyle things that you can do every single day will make much more of an impact on how you feel, on what you can do, on your shortness of breath, than the medications, okay? So if we have the medications, and the medications can stop or slow down the progression of the fibrosis, then it takes the rest of that stuff, and that's what's going to change how you feel day to day, okay? So the thing is that, what do we talk about when we talk about IPF? The number one symptom is shortness of breath, right? But there's a lot of reasons why people get short of breath. Shortness of breath is a multifactorial symptom. So does pulmonary disease make you short of breath? Absolutely. Can heart disease make you short of breath? Absolutely. But can simply being out of shape make you short of breath? Definitely, okay? There are people who are 45 years old that don't do any exercise, that are 50 pounds overweight, they get short of breath going up the stairs. So what I want to try to just open your eyes to is the fact that people will get this diagnosis of IPF, and then everything that happens is attributed to the IPF. Say, oh, well, you know, I'm much more short of breath, I'm more fatigued, it must be the IPF. You know, oh, stub my toe, it must be the IPF. It's not like that, or it might be like that, but even if it is the IPF, we have to start working on some of these lifestyle issues in terms of what you can do every day. And these are things that you can do right now. So let's start. So I have a concept called ultimate pulmonary wellness. And in my opinion, there are 5 things, and I mentioned them already, but I'm going to mention them again, that really will make the biggest difference day to day. And you know, there are people around the world that I talk to that I call cardiopulmonary outliers. And these are people that, despite a serious disease, are excelling in what they do. And Bill Vick is one of them, and Bill calls his, his philosophy space, okay? And I'm sure you've heard me talk about that before, but all the people that I talk about that despite these diseases are excelling anyway, are all doing very, very similar things, okay? It's like when 3 artists come out of totally different parts of the world and their work all looks similar. You say, how does that work? But I think that the real keys are 20%, I don't want to say 18%, I would say 18%. One of the things, don't feel the need to write notes on everything. I'm going to record this, it's going to be on our web, you'll be able to watch it as many times as you want, but I really want you to be present in the room and not just think about what I say, feel what I'm saying. Let's get this collective energy like moving so that we're all, I see people shaking their heads. This is, I hope to be a really special experience where we're kind of like, I feel this energy in the space as opposed to like me lecturing at you, okay? So number 1, 18% medical, I call it, okay? Medical is having the right doctors, having the right program that you belong to, taking the right medicines, and taking them properly, okay? So I've had an opportunity to see Baylor's program, looks great, okay? But having the right doctors, taking the right medicines, taking them properly, that's 18%. The next 18% is exercise, and there's a lot of talk about exercise. What can you do? What can't you do? What should you do? There's a lot of experts out there that are telling you stuff that is 25-year-old thinking, okay? Everything I'm going to tell you today is based on not anything I've read, it's based on my own work that I've been doing day in, day out with pulmonary patients for 25 years. Okay, I know what works best because we've tried everything. Or, if it's out there, we've tried it. And there's reasons why we came to what we do now. And I'll talk about exercise in great detail. Nutrition is so important, okay, for people with lung disease, but particularly IPF. And contrary to many situations where people being overweight is the problem, at a certain point, once you get to a sort of critical point where breathing becomes a regular physical activity, where you're working so hard to breathe and you're burning so many calories, keeping the weight on is an issue. And I think, it's amazing. I'm writing a book now called Ultimate Pulmonary Wellness, and one of the most challenging chapters was the nutrition chapter, because it's so hard to find somebody that actually knows what people should be doing, particularly as it relates to lung disease. So if you look at cardiovascular disease, a ton of people are going to come out and say, you need to do this, you need to do this, you need to do this. But if you have lung disease, particularly if you have IPF, the food pyramid is not your friend, okay? Those, whole grains, and I'll get into it in more detail, but nutrition is crucial. And if you're not doing anything to think about your nutrition right now, that's the number 1 thing I would say to you right now, okay? Next, stress management, relaxation. It sounds like, I'm not talking about laying on the beach in Miami, unless you find that relaxing, then do it. But this is a stressful, anxiety, fear-provoking disease, okay? And this fear and anxiety, it doesn't exist in a bottle, okay? It doesn't just happen and, it's a huge physiologic process, okay? You've heard about the fight or flight response, so tons of chemicals are going on. I'm going to get into that also, okay? So stress management, relaxation, and then prevention of infection, okay? Because a cold to you is not a cold to me. So a lot of people came in and tried to shake my hand. I tell you, I don't shake hands, okay? I just wrote a chapter on how to prevent infection, okay? So now, my parents were both sick last week. I was like, sorry, but I can't come to the house. You can't come to my house. But it sounds funny, but it's so important, because if I shook everybody's hand here and one of us had a cold, then everybody after the hand I shook with that cold, you've all got it, okay? So that's really important. So now those are the topics, okay? After knowing what we're going to talk about, anything else you want to talk about besides that, and then we're going to go hot and heavy, All right, so let's talk about this. So I already mentioned medical care. So having the right doctor, pulmonologist, cardiologist, gastroenterologist, surgical team. Okay, to me, those are the minimum. Why? Okay, when we talk about lung disease, there's a lot of symptoms that occur with lung disease that are the exact symptoms of heart disease. Okay, when we talk about shortness of breath, it could be a lung issue, and it could be a heart issue, and it could be a gastrointestinal issue, because between here and here, we got a lot of systems, and those systems are crunched up really tight. So if something's going on here, well, it's kind of close to my heart, and it's kind of close to my lungs, and it's right around my stomach, but we don't know, okay? A lot of people with respiratory disease also have heart disease, and also could potentially have gastrointestinal disease, but I want to make sure that I know what we're talking about, okay? And that involves the right diagnostics in all those three systems. So it's really the lungs, okay? And if you've got a diagnosis of lung disease, we know we're dealing with that. But it doesn't mean that just because you have lung disease, unfortunately, that, you know, it's not like take run, you know, and that's it, you check you off. You could also have heart disease, and you can also have gastrointestinal. So if somebody starts talking about shortness of breath, chest pressure, chest pain, or discomfort over here, I want to make sure it's not your heart, okay, before anything else goes on. So I think anyone who's diagnosed with a lung disease, it's worth your while to have an appointment with a cardiologist, at least for a basic workup. Let's make sure that there's nothing going on. I think stress testing is very valuable. I think stress echo is very valuable, because as lung disease progresses, we can also see cardiovascular and heart changes that occur as a result of the lung disease. I also didn't mention internal medicine, and of course, you know, if you have a great internist who can sort of jockey your team, that's well also. But you know, your care can be managed by any one of the above. Okay, gastrointestinal disease is also something that's really important. A lot of people with respiratory disease, because of coordination of breathing, because of the compression of the thorax and the abdomen, can also wind up with reflux. Okay, I asked Dr. Robert Kaner, who's like our best ILD guy in New York City, among a few others, what would be the #1 suggestion that he gives to people with interstitial lung disease or pulmonary fibrosis? And he said, check if you have reflux. And if you have reflux, make sure it gets treated, okay? Because lung disease can increase your chances of reflux, right? We have the trachea and the esophagus, so the trachea brings air into the lungs. The esophagus brings food and drink into the GI system. They're very close together. And if you're working hard to breathe at the same time you're eating, your lung disease can impact your gastrointestinal system. And your gastrointestinal system, if stomach acid is coming up, can flip over into the airways and affect your respiratory system, okay? So again, if you have a diagnosis, having the right doctor means the right lung doctor, the right center, the right lung center, and looking for centers of excellence for interstitial lung disease, cardiology workup, and at least to rule out heart disease, and gastroenterology. The other thing is that there's something called silent reflux. Okay, so a lot of people can actually have reflux and not know it. So if you have this heartburn and you wake up and you have a bunch of stuff in your throat every morning because it's dripped down overnight, that's classic reflux. Okay, one of the things about classic reflux, but you can also have silent reflux. And even though it's silent, you don't have any symptoms, that acid can get into the airways and definitely increase inflammation. So that's medical. Taking the right medications, taking them properly, okay? And that's medical. Any questions or comments about that?
I have a question on that. I have not had an issue with the reflux or that, but when as I've been taking Esbriet, that has been something that has started, and my pulmonologist put me on the something, I call it
Pantoprazole?
Yeah.
Okay.
For that, and even though I don't always feel it, it is something, and for that very reason.
Right.
And that was one of the first questions she asked me as I started taking it was, are you having heartburn, are you having those issues? And it's come and go, but I do take that now every day just because that's been a symptom of
Right.
An effect of the Esbriet.
Right, absolutely. So pantoprazole is in a class of medications called proton pump inhibitors. So that's like your Nexium, omeprazole, Prilosec, things of that nature, okay? So that's a great thing to do because again, like I said before, we're fighting a war, right? So we're fighting this war and we don't want to lose ground on something stupid, right? It's like saying, hey, we didn't realize we left our tent open and a bear crawled in and ate all our supplies, okay? You want to make sure that you're fighting that more, and you don't want stomach acid coming up and, you know, kicking up inflammation in our already inflamed respiratory system. So that's awesome. I'm not saying what you should or shouldn't do. I'm saying these are things, if you're not doing them, talk to your doctor about it. Okay, I don't know any of you except Bill. You know, I would never come here and give you advice. This is what you should be doing, but at least raise the questions and say, hey, you know what? I was at this lecture. Do you think that we should look into reflux? Is there anything I should be taking? You know, do I need to look into my heart? Okay, let me just talk about one other thing as it relates to the heart and the lungs. Okay, a lot of times people with coronary disease. Okay, when I talk about the heart, there's three main things that I worry about. There's three things that I feel like could get you in trouble very quickly. Like IPF is not going to get you in trouble overnight. Okay, it doesn't work like that. Okay, the heart can. And when I worry about my patients, when they come in, I do something called risk stratification, which is where I say, these are the things that might get my patient in trouble during their rehab stay. Three things related to the heart. Number one, coronary insufficiency. And coronary insufficiency relates to the circulatory system of the heart. So how does blood flow through the coronary arteries and supply the heart muscle itself? So like when somebody says, angina, squeezing chest pain down the left arm, but that's the classic, you know, coronary symptom, but you can get it in other ways, and I'll talk about that too. So coronary insufficiency, arrhythmia, right? So that's the electrical system. So coronary insufficiency is the circulatory system. Arrhythmia, like a lot of people with lung disease wind up with something called atrial fibrillation or supraventricular tachycardia or things of that nature, okay? And then the third is heart failure, okay? So those are the three things that I want to make sure absolutely before I do anything with you, that's ruled out. And if I ever have any doubt about that, then I am going to send that patient back to their doctor for a workup before I'm willing to push you. And the point I'm making here is that some of the symptoms are similar, and if you have a lung disease, then very often what happens is, oh, you're short of breath walking uphill, it's your lungs, okay? But we also know that IPF can make you at greater risk for right heart pressures, and we know it can make you at greater risk for heart failure, and shortness of breath is one of the symptoms of heart failure. But the other issue is that because of lung disease, a lot of people may not get up to the level of activity that elicits their cardiac symptoms. So what do I mean by that? Most people talk about, you know, when I say to people, what, you know, why are you short of breath, or what makes you short of breath? So in my practice, everybody's short of breath. Okay, that's all I treat. People go short of breath, and it could be from COPD, it could be from interstitial lung disease and pulmonary fibrosis, it could be from heart failure, it could be from pulmonary hypertension. Those are my biggest areas of interest. But the mechanism of what makes them short of breath is what makes things different, okay? But the thing that I hear most often from people is walking upstairs, and in New York City it's walking up subway stairs because they're not built for comfort, they're built for efficiency. It's kind of like walking up that stairway to heaven, walking uphill and walking fast or running for the bus, okay? So we call that the New York City triathlon for pulmonary patients. I don't know what you do here in Dallas, but walking upstairs, walking uphill, running for the bus. Anything else? Walking fast. What's that?
Getting dressed.
Getting dressed. Showering. Awesome. We're going to talk about those two because that's something that nobody understands, everybody complains about, but when I tell it to you, you're going to be like, why didn't someone tell me this 25 years ago? Okay? But we'll talk about that too. So here's the thing about shortness of breath. When people get short of breath, okay, they start getting short of breath at high levels of activity. So if I know that walking up subway stairs makes me short of breath, then I'm going to take the bus. So imagine if I walk up 4 flights of subway stairs a week, and I work 5 days a week, which I don't, I really work 7 or 8 days a week. But that's 4 flights of stairs, 5 days a week. That's 20 flights of stairs that I'm no longer walking up and down because I'm now taking the bus, right? So that doesn't just affect my lungs, that affects my heart muscle, that affects all these muscles. It also affects lung function, okay? There's a lot of people who are going to say, you can't affect lung function with exercise. I don't believe that. I think you can. I think you can improve it in a lot of situations. I think for the people that say you can't, I think they're not exercising people vigorously enough, okay? And we'll talk about that. But people start to get short of breath, high levels of activity, they eliminate those activities, and now they start to get short of breath at lower levels of activity, okay? Then they start to eliminate those. So maybe now I know that if I have to go up 59th Street, then I'm going to walk up a hill, so I'm not going up 59th anymore. I'm going to take a flatter surface. Now all the muscles I used to walk uphill get weaker. My heart gets weaker. My lungs become less efficient. Then I get short of breath when I walk fast, so I'm not going to walk fast. right? So how many people, when you have this experience, a lot of times people will say, you know, I'm walking with my friend, and I have to come up with an excuse to stop so I can catch my breath. I don't want to tell them I can't breathe. Or I'll be walking the street, and I'll stop and look in the store windows, right? Because I don't want people to know I'm short of breath. But the point is, what I'm trying to say about this is that you can get significantly more short of breath. And let me tell you one thing. If you look at the classic literature on pulmonary rehab, they will say that patients get better, they feel better, they can do more, they're less short of breath, but there's no change in lung function. Now again, I told you I don't believe that already, okay? But let's take that as if it's the truth, okay? What does that tell you? You're less short of breath, you can do more, you feel better, you're less anxious, but there's no change in lung function. What does that tell you? That tells you that there have to be other factors besides just the lungs that either make us more short of breath or less short of breath. So my point is to tell you that, not to say, okay, like I said before, if we do nothing, this car will get better or get worse, and I can somehow get less short of breath or more short of breath, I'm gonna choose less. I'm gonna choose to do the things that I do. Okay, we have more control over going to the gym and not eating that Arby's Big Boy and not letting stress take over our lives, okay? And washing our hands. Those are things we can control. So I'm not here to say, hey, you know what, and I don't want to turn this into a meeting about, give me the serenity to change it. But that's really the truth, okay? Other than take your medications, there's not a whole lot that we can do to change the progression of the disease and transplant and those types of things. But the everyday stuff, I'm telling you, that's the 80% of it. That's the stuff where you're gonna feel totally different, and not only that, you are no longer a victim. You're not waiting for the disease to come up and take a bite out of you while you're floating on the water. You're saying, you know what, I may go down. We're all going down to something, we don't know what, right? We're all going down. But like I said, if I'm going down, I'm gonna go down punching and kicking and fighting and screaming, and the way that you do that is what you do every single day, okay? I'm not gonna sit here and say to my lungs, stop making scar tissue. Please stop making scar tissue, please. But I could say, hey, you know what? I'm going to the gym. I'm going to kick some ass in the gym, or I'm going to eat this, and this is going to make me feel good instead of making me feel like crap for 4 hours. And I'm going to do some meditation because I need to turn off these voices in my head, and I need to turn down all this adrenaline that's shooting through my system every day, because all those things make a difference, and all those things can change the progression of your disease, or at least the things that can impact how you feel, because these things are all chemical and they're all inflammatory. More and more, I'm starting to think that inflammation is the key to life or death, okay? Meaning that stuff how does stuff get in? It'll get in through our eyes, it'll get in through our nose, it'll get in through our mouth, it'll get in through our gut, okay? And if you want to think that you only have inflammation in your lungs, no. If you got inflammation in your lungs, you got inflammation in other places. If you got inflammation in other places, you got inflammation in your lungs. And so the point is, I want you to start doing things to quiet that system down. That's medical, 18%. Let's go to exercise, okay? What do you want to know about exercise? I'm going to tell you everything anyway, but specifically, what are some questions or concerns?
How hard can you go?
How hard can you go?
How frequently?
How frequently?
Best exercises.
Best exercise. Anything else?
Intensity.
That's how hard you can go, yep.
Use oxygen with your.
Best way is to use oxygen. Okay, awesome. So this is what we just talked about. So there's a formula. It's called FIT, right? You guys just did it for me. So it's like frequency, intensity, time of exercise, type of exercise. Those are the 4 things you can change about exercise, okay? Frequency, how often? You guys are going to answer those. So how often should you exercise? All right, my work is halfway done. Every day. It doesn't mean you have to go to pulmonary rehab every day. It doesn't mean you have to go to the gym every day, okay? But let me tell you, this is like money in the bank. Everything we're talking about now is money in the bank. So if you do nothing, and it's not like you do nothing, your bank account doesn't change, okay? You do nothing, your bank account goes down. So every day that you do nothing, and when I say do nothing, I'm talking about you don't exercise, you don't eat right, you don't do any meditation, you don't take your medications right, you don't wash your hands 50 times, okay? Every day we do nothing, stay sedentary and make no action, we're losing money, right? Every day we're doing something, it's like putting money in the bank. And you're gonna say, well, some days I wake up, I can't think of doing anything, right? So you know what? Put a penny in the bank. We're still moving forward. We're still moving. And on the days that you feel great, it's like surfing. You go out, there's no surf, no waves, go home. The waves are there, you ride them. You have a good day today, you feel great. Usually you walk a mile a day, but today you feel great. Walk a mile and a quarter. okay? Don't set the limits in your head before the limits present themselves by your body. And that's what happens too often is we say, oh, I have an IPF, I couldn't possibly do that. And then you go to certain doctors and the doctor say, you know what, you have IPF, you get your, take it easy, okay? And you go to the therapist and some of the therapists, you know, they're saying, well, look, let's take it easy, let's teach you how to slow things down. I'm gonna tell you something right now. If you learn anything from this one thing, here's the message. Everything I just said, slow it down, take it easy, is the opposite of what you need to be doing. You need to pick things up, you need to not take it easy, you need to get it in gear, you need to fight. And that's what's gonna get you going. And maybe today's not your best day, okay? So, but I'm gonna put something in, okay? It's like, I'm gonna put something in today, every single day. And I'm gonna put a chart on my refrigerator that says medicine, exercise, nutrition, stress management, prevention of infection. I'm putting at least one check in the box of every one of those boxes. And I promise you, those things don't add up, they multiply. And it's scary to start, okay? When you go and nobody's giving you any information, you're like, I have this disease, I don't know what it is. Let me tell you something about interstitial lung diseases, okay? And interstitial lung diseases are so complex, okay? And so for the doctors that understand, Dr. Wong is a humble guy, okay? He's just a regular hip-hop doctor, okay? But interstitial lung diseases are so difficult to understand because nothing makes sense about it, okay? The names don't make sense, the treatments, you know, are hard to understand. Even pulmonologists often, who are long experienced pulmonologists, have a difficult time with the interstitial lung diseases. So we can't possibly expect that you are going to understand it completely, but you have to understand it at least a little bit, okay? So exercise, let's talk about that. So frequency, we said every day. As I said, you don't have to go to pulmonary rehab every day. First of all, we know your insurance isn't going to cover that anyway, okay? But you should be doing something every day. Could you go to pulmonary rehab twice a week, 3 times a week? Yeah, because pulmonary rehab is the time where you're going to be pushed to your maximum, hopefully under monitored conditions, okay? And that's the time to push yourself, okay? But on the other days, walking, okay? Strength training, bicycle, anything that you have, okay, it's like Nike says, just do it. I'm going to say, just do something, almost anything, and it's going to be beneficial to you. Maybe it's not putting $100 in a bank, maybe it's putting $5, $10, $20 in a bank, okay? There's something else called armor size, which I will make this program available to you, but it's things like uppercuts, stir the suit, upper body stuff, and we'll talk when we talk about, you know, showering and dressing, why the upper body is so important as well, and why you get so short of breath when you're taking this different, when you're doing these different upper body activities in particular. But you should be doing something every single day, okay? Again, every day that you're doing something, we're holding that car up the hill. Every day that we're doing nothing, we're bringing it down. Frequency every day. Intensity. This is the, yes ma'am?
Time of day.
Whatever's good for you, okay? There's no particular time of day that's gonna make it more, I'll throw one seed out to you. The thing I like about exercising first thing in the day, okay, there's a lot of things I like about exercising first thing in the day, okay? Here's one thing. Let's talk about it from a heart rate, blood pressure, anxiety perspective, right? If I start my day here, right, and this day is getting all over me and it's stressful and it's anxious and all that, and my blood pressure and heart rate get up here, and then I exercise and it brings it back down to here, right? You with me? Now here's something else to think about. Let's say I start here, and before I even get a chance to go to work and the boss is a jerk, not at my place, but although Caroline's gonna be like, no, he's a jerk, you know, but you start here, right? And then you do your exercise and you come down here with your blood pressure and your vessels open up and your heart cools up. And then whatever your day gets, it only brings you back to here. So you see like your max is not getting as high there, okay? Because we know that stress and you know, blood vessels and all this stuff plays a role in hurting us. So that's one thing about exercising first thing in the morning. And the other thing is that no matter what else happens in the course of your day, and you know that something happens every day, you've done it already. You've done it already. So that when you come in and you're cool, and you know the effect of exercise when you're actually doing it, the acute effect is that it's going to increase your heart rate, increase your blood pressure, maybe decrease your oxygen saturation. But after the exercise is done, guess what? The blood vessels are nice and wide. Your heart is pumping nice and efficiently, okay? You're breathing nice because your airways are relaxed, right? You also have smooth muscle inside your airways. And that smooth muscle is very susceptible to the course of the day. So like you see football players like exercising, and if it's a cold day, they have to take extra time to stretch out. right? But you have smooth muscle inside your airways, and if you go without that muscle, tightens up and constricts and gives you less room for air to flow out, as opposed to if you exercise and you do it all in a controlled way that makes sense scientifically, your airways open up. So a lot of times people will try to get out of rehab by saying, you know what, I'm really having a lot of shortness of breath today. And we don't want you to come if you're sick. We don't want you to come if you're having an exacerbation, if something's really wrong with you. But if it's just, we know that there are going to be things that get in the way of our day. If it's a smoky day, if it's a humid day, if it's a cold day, that's going to make it more difficult to breathe. And if nothing's wrong, if you're not actually sick, I'll say come to rehab, because I know that after the exercise, your heart will be more efficient. It'll be pumping more blood, bleed, stroke. Your airways will be relaxed. Your blood vessels will be open. And a lot of times nowadays, people walk out and say, boy, I'm glad I feel so much better now. And that also, all these things plant little seeds in your mind. And those seeds grow and you're like, oh, I'm more short of breath. What's going on? Am I getting worse? Is my disease getting worse? And those are the things, some of it's real, but a lot of it is not real. And so I say to people again and again, I say this to people in everything that they do. Don't let your brain, don't let your thoughts limit you before your body gives you the real indication that something's wrong. So time of day, if you can do it in the morning, that's great. There's another aspect to this, which is that the relationship between exercise and eating, okay? Because a lot of people probably feel that after a meal, okay, it's harder to breathe. And so that's not the time. Now there's a whole bunch of physiological issues that go on with that. So we talked about, I'm going to talk a little bit about the autonomic nervous system. So I'm not going to make this super scientific, I'm going to just break it down easy. So there's two nervous systems that we talk about, the autonomic and the voluntary. So the voluntary is, I want to raise my hand, I do it. I want to put my hand out to the side, I do it. But I don't have to stand here and say to myself, to my heart, I don't have to say, beat, 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 right? I'd be exhausted just from beating my heart. And when I go to sleep every night, my heart will stop beating. Same thing with breathing, right? Now, breathing is interesting because breathing has combinations that are voluntary and that are autonomic. So can I say breathe hard and fast? Yeah, I can do that. But at a certain point, I can hold my breath. But at a certain point, my body's going to say, no, you're taking a breath, whether you like it or not, okay? So there's autonomic and voluntary control. So we want to control the voluntary part of it, but we can also do some things to control the autonomic parts of it. So there's autonomic system is then further divided into sympathetic, parasympathetic, right? You hear these things all the time. People are like, oh, I was getting mixed up, sympathetic, parasympathetic. So it's like sympathetic, think of it like this, it's your friend. It's there to help you. Another way to think of sympathetic nervous system, fight or flight. So I'm walking, all of a sudden, 6 Texans walk, no, I'm just kidding. But I'm walking, and all of a sudden somebody jumps on me, or a bear jumps out, or a pterodactyl, a caveman. But it sounds funny, but that's how this all came about, right? So you're walking out picking berries, caveman is walking and picking berries for family, and a pterodactyl comes and tries to sweep them up. So we have two options now, fight or flight. So you've heard about the fight or flight response, right? So this pterodactyl, I don't want to become pterodactyl food, so I can either fight this pterodactyl or I can run away. And your body has a lot of adaptations that it does to do that. So think about what would be beneficial to you. So would it be beneficial for all the blood to rush to your stomach because you just ate? No, we want the blood in our arms, we want the blood in our legs so that we can fight. We want our heart pumping hard, we want to breathe, we want our airways to open up, we want our eyes to open, and we want our pupils to allow us to see when that pterodactyl is coming. That's fight or flight. So that originally came from a very prehistoric, primitive protection mechanism, except that in today's times, today's times really more than any other times I've ever seen. I'm not going to make any political statements because I am in Dallas and I'm from New York. But if someone's writing a check on the checkout line before us, and we're like, oh my God, this lady's writing a check. Every time I come here, this lady's in front of me, she's writing a check. I'm in a rush. That is having a very similar, maybe not to the same degree as if a pterodactyl is trying to sweep me up, but my heart starts beating faster. My blood vessels constrict, my airways can tighten up. Well, airways shouldn't tighten up, but this is the effect of adrenaline, because I am getting ready to fight or flee, but I'm not gonna fight the 85-year-old lady writing a check in front of me on the checkout line, but I'm getting mad, and without an outlet for that, that outlet being exercise, fighting, or fleeing, it constricts your blood vessels. It makes your breathing more difficult. Okay, that's the sympathetic nervous system. And rest and digest is the opposite. So that means, so it's coming up to Thanksgiving, right? We all have this experience where the night's over, we've stuffed ourselves and we're like, oh God, I could fall asleep right here. And granted, everybody blames tryptophan, okay? Hardly blame it on turkey, but a lot of it has to do with the fact that there's so much food in here, okay? And we get a huge amount of blood flowing to this area, away from our brain, away from our, so if I said to you right now, all right, get up, we're gonna get on the treadmill, that's the last thing you wanna be doing at that time, right? But the other aspect about eating and respiration is that there's a mechanical issue, right? So if you know a little anatomy, we know that the lungs are here, the diaphragm is a dome-shaped muscle that sits here, right? And it contracts downward, and when it contracts downward, that's when it inflates the lungs, right? And below that is all of our gastrointestinal content, so our intestines and our stomach and all that stuff. So the more you have here, the more that's pushing up against the diaphragm, and the harder the diaphragm has to work to contract downward and to open up the lungs. And the other thing is that if it really pushes up, okay, then guess what? That's compressing our lungs even more. And we know that with pulmonary fibrosis, we're already going to have, compressed lungs as well. So think about it like this. If I have a glass of water and I have a Dixie cup, okay, and I want to fill up a bucket over on the other side of the room versus having like a 64-ounce beer mug, then with that Dixie cup, think about how many more trips I have to make in order to fill up that thing right here, as opposed to a 64-ounce mug. So it's the same thing with breathing, right? So the less air you move in and out with each breath, the more you have to breathe, right? The more frequently you have to breathe. It's a very simple formula. There's something called minute volume, which is the number of breaths you take per minute times the amount you move in and out with each breath, right? You multiply that, that's how much is moving. Now you can do that in a lot of different ways. So if I'm taking a breath, that's 500 milliliters per breath. In order to get up to 6 liters, I only have to take 12 breaths per minute. But a lot of people here, most people here, are not taking in 500 milliliters per breath, right? Some people may be only taking in 150 milliliters per breath, or 200. So at 150 milliliters per breath, instead of those 12 breaths per minute that I'm taking, so that's 1 breath every 5 seconds, I instead have to take 40 breaths per minute. So that's 1 breath every second and a half, and that looks like this. And I'm sure a lot of people here know what that feels like. There's a lot of problems with that, okay? First and foremost is that the trachea, the airways, the windpipe, okay, holds about as many milliliters of air as you are pounds. So if you're 150 pounds, okay, some people are saying like 150 pounds, let me get to 150. Some people are saying, I wish I was 150. But if there's 150 milliliters, if you're 150 pounds, that means you have to get at least 150 milliliters of air to pass the windpipe, because nothing in the windpipe gets into your bloodstream. That's the whole idea behind controlled breathing techniques, and that's why we teach you these controlled breathing, to try to get as much air out and also to take as much air in, okay? You know, I come to meetings sometimes, it's like the Jets and the Sharks, the COPD patients versus the IPF patients. It's like, this doesn't apply to me, I have COPD, or this doesn't, it applies to everybody. It's yin and yang. So what goes in, what goes out. If you have a problem with inspiration, you have a difficulty with exhalation as well. So don't think of it as that. But the key is you have to surpass that. So if you're breathing 40 breaths per minute and only moving 150 milliliters of air per breath, and you're going, none of that's getting into your lungs. So the eating and then exercising, or the eating and breathing, that's the connection between eating and breathing, okay? So we talked about anything else related to frequency of exercise. That's where we're talking about now, and then I'm going to get to intensity. Frequency. Intensity of exercise, the cosmic question, how hard should I work out? I have a YouTube video on it, but I'm going to tell it to you better than it is on the YouTube video right now. You have to work out pretty vigorously. Okay, you have to work out almost as hard as you can. Now, let's talk about what are the keys. So the keys to working out vigorously, it's got to be safe. Okay, so we don't want you overdoing it, but at the same time, we don't want you underdoing it. This is like Goldilocks of exercise. We don't want it too hot, we don't want it too cold, but it's of course worse to overdo it than to underdo it. But if you think about the potential benefit of exercise, by underdoing it, let's say if you only get 50% of the benefit because you're afraid to push yourself, and you multiply that by 100, think about how much of a disservice you're doing to yourself. And part of the problem is that the healthcare professionals are saying to you, when you get short of breath, you should, you need to calm down. You need to take it easy. You need to stop. But by learning controlled breathing techniques, okay, and understanding the science behind what's okay and what's not okay is crucial. So how do we know if we're okay or not? Okay, I'll tell you what I look at. First of all, I like to do an exercise test on every patient, okay, because I want to know what they can do and what they can't do. But let me tell you some of the problems with exercise testing when it comes to pulmonary patients, okay? If you look at the classic protocol, the most common protocol that people use is called the Bruce protocol. And the Bruce how many people here have had a stress test before? Okay, treadmill test, right? So the most commonly used protocol, and I'm saying like 90% of people who get stress tested get this protocol called the Bruce that starts at 1.7 miles per hour, 10% incline, right? That is very, very vigorous for a lot of people to start. If you get through the first 3 minutes, it goes to 2.5 miles per hour with a 12% incline, even more vigorous. And if you get through 6 minutes, the next 3 minutes are going to be 3.4 miles per hour with a 14% incline, okay? So the problem is, what stops the test? So if you think about your last exercise test, why did they stop you? What's that?
Perfect.
Sometimes, okay, sometimes heart rate, sometimes blood pressure, but more often than not, the tests are stopped because the patient is short of breath or their legs are too tired because they're not used to activity. So a lot of times I'll get a stress test report and it'll say like patient did 1.5 minutes of the Bruce protocol, negative for ischemia, which means that we're ruling out heart disease based on that 1.5 minutes. However, they only did a 1.5 minutes. Okay, so they didn't really reach a heart rate. They didn't reach their peak heart rate or their maximum age predicted heart rate. They didn't reach their peak blood pressure and their oxygen saturation. Very often they don't even measure oxygen saturation during a stress test, which is a huge problem, for people with respiratory disease. And a lot of times they'll stress test people without oxygen. Okay, so if in the first 2 minutes of the test you're at 70%, we have no choice. We have to stop the test. Whereas maybe if we would have tested you on oxygen, and I'll talk a little bit more about how much oxygen you should get and how should you get that oxygen, but that test is almost useless to me because we've ruled out heart disease, but I didn't see any cardiovascular or hemodynamic endpoint that tells me we should stop the test. Now, there's a peak heart rate. There's an age-predicted maximum heart rate, which, in most circles is 220 minus your age. So if you're 80 years old, we would say your maximum heart rate, age-predicted, should be 140. That's the normal healthy population. But if you have heart disease, if you have lung disease, a lot of medications that people take will alter their heart rates and make them either faster or slower. So I don't want to know an age-predicted. I want to know the actual for you. So there's the predicted, there's the actual, and there's the actual. So when I say the predicted is, I know your age, I can do math, I can subtract your age from 220, that's your theoretical maximum heart rate, but your actual maximum heart rate is what I will see on the stress test. So if you did a stress test and you may be 70 years old, so your theoretical max heart rate would be 150, but on the test you only reached 130. Then I can only say what happens up until 130. Anything after that, I don't know. It's like we know this plane flies up to 25,000, safely. We don't know what happens after that. Same thing with the heart rate. And then when I say the actual, I mean, yeah, we may have just done this test and gotten 130 on you, but if the reason for stopping the test was shortness of breath and lower extremity fatigue, then this is less useful and we have to look at other factors as well. So that's one thing. The reason why I'm talking about exercise testing is because the exercise test, based on those results, will set the intensity of exercise that you're going to work out when you go to rehab. So, for example, they may say, yes?
Should all of us have had a physical stress test?
I believe you should. I believe if you have IPF, then you should have a stress test. Why? Because there are, it could increase the workload on their heart, could increase your chances of arrhythmia, and there's no harm in doing it. It's one day, you get your test, you find out if you have something or if you're not. And then if we rule it in, it needs to be treated and addressed because maybe that was contributing to your shortness of breath in addition to pulmonary fibrosis. And if it's ruled out, then when you're walking up the hill and you feel it squeezing in your chest, you can say, I know it's not my heart because I've already had it checked out, right? I don't like to guess. I don't want to be like, what's your name?
Barbara.
I don't like, Barbara, come here, let me see you do some push-ups. Let me roll the dice and see if these push-ups knock Barbara out. You know what I mean? I want to know for sure. I don't like surprises. So, yes, sir.
How often do you do stress tests?
Depends on your doctor, okay? But I think if you're diagnosed with a lung disease or anyone who's really having symptoms of shortness of breath, chest pain or pressure, reduction in exercise tolerance all of a sudden, so you used to be symptomatic walking up 4 flights of stairs, now it happens on 2 flights, or you used to walk, get short of breath, only walking uphill, now it happens on flight. That's a baseline, you know what I mean? Let's at least get the baseline. Let's deal day to day. Let's deal day to day, month to month, year to year, and let's make it based on science. Let's make it based on your symptoms. So if there's a change, okay, then by all means, let's look at it. But a stress test is the beginning. A lot of times we can have false negatives, we can have false positives with just a straight stress test. And most stress tests, you're walking on a treadmill and there's a 12 lead EKG. Ideally, there's also going to be what's called a stress echo. So as soon as the test ends, they do an ultrasound of your heart because we know that pulmonary fibrosis can also increase the pressures in the pulmonary artery. We know that that can also go back and increase the pressures and the workload on the right side of the heart, right? The right ventricle, the tricuspid valve, the right atrium. And the right side of the heart, is the side of the heart that's usually the low pressure side of the heart. But because of lung diseases, very often that can also be high pressure side of the heart, except the problem is that the machinery on that side is not built for those pressures. So again, I think it's worthwhile to get the stress test, get the echo, let's see the baseline, let's see how things progress as time goes on. There's no harm in information. The more information we have, the better. And I'm not advising willy-nilly go get a test every week. I mean, but let's get a baseline. Based on that, let your doctor implement some treatments. Let's see how those work out. But guess what? Maybe if you're also having increased heart issues as well, and then those are treated, maybe now you're much less short of breath, and you had a combination of lung and heart issue or something like that, and now we'll exercise. But I would say at least a year, not every year necessarily, but again, if your symptoms change, if things change, then you got to look at it. I don't want to assume, it's probably this. You hear a lot of it's probably this. Maybe it is, maybe it's not. I want to make sure I know what it is.
How about nuclear stress tests?
I think they're great, particularly for people who can't do the treadmill, right? So the nuclear stress test is basically where the chemicals are going to do the work for you. Okay, so that is not going. Pharmacologic tests are not going to make you walk on the treadmill. So for the person who's too short of breath or who has orthopedic limitations or things like that, the nuclear stress test will get to the bottom of it. But it's not. You want to give people unnecessary radiation if they don't need it, but you always start small. It's like if I see a bee, I'm going to try to, I'm not going to hit them with a hammer first. I'm not going to hurt the bee anyway while I'm talking about it. But you want to start with the basics and work your way up.
How do you determine whether you need the physical stress?
Ask your doctor. Your doctor should know it, okay? Like your internist should recommend you to. But here's the thing. A lot of doctors may not think about it, okay? They should. A lot of doctors will. And Dr. Long, don't jump me after this. I'm not bad-mouthing doctors, but a lot of times things get missed where someone doesn't think of something. So the question I would ask is, do you think I need a stress test? Okay, what kind of stress? Because a lot of people don't even know what a stress test is. Okay, or they have this idea, or a lot of people will say, did you ever walk on a treadmill? They say, well, yeah, when I had my stress test, and they had to pick me up and throw me on a gurney and start, that's the worst experience, right? But understand that the stress test is designed to cause stress, right? Like for me, I'll just sit in a chair and I'll have people come and nag me all day, and that'll be, tell you if my heart is in good shape or not. But the thing is, people don't know that there's different kinds of stress tests. So the most basic is a regular stress test, EKG only. Okay, it's going to tell us about the electrical activity of the heart, but you can have false positives, false negatives. If you're going to go that far anyway and get a stress test, get the stress echo, because then we also learn about the mechanical function of the heart as well. And those two things, the electric and the mechanical, remember I talked about the 3 risk stratification before. That's going to tell us about arrhythmia. It's going to also tell us about circulation. It's also going to tell us about pumping power of the heart. So that's one thing, okay? So back to, we're talking about intensity, and this all leads up to intensity. Yep.
Sorry, one more. Is there an age at which you would start with the physical stress test?
No. You mean, can you be too young or too old?
Too old.
No. No. Absolutely not. I mean, everybody, but again, it's about choosing the right test. I mean, listen, I spend most of my day around people who are between 80 and 100 years old. Okay, and I'll show you some videos. You're gonna, when I show you these videos, you're gonna be like, what? you know, you're gonna check your eyes because you're gonna see people working out who are 85, 90 years old, working out vigorously, and they're not different than you, okay? They're not different than you. You guys are my people with a funny accent, okay? You know, so they're not different. The reason I'm gonna show you these videos is because, you know, people look at this stuff and they say, no, that's not me, that's too much. And I'm gonna show you it's possible, okay? These are not young people and old people maps, but the point is that you wanna check it out, make sure it's gonna be safe. Now here's why I say that the predicted, the actual, and the actual. If you, and this is a mistake that you know a lot of people make, which is that if I get you up to a test, and the reason why we stop the test is shortness of breath and lower extremity fatigue, but your heart rate's good, your rhythm's good, your blood pressure's good, and your oxygen is good, then for me to cut that workload and say, like a lot of people say, well, you're gonna work out now at 60% of that workload, right? Or 80% of the workload, thinking that that's your maximum heart rate or your max workload, but it's really not, because it wasn't the hemodynamics that stopped the test. The test was stopped by your breathing and this. So I would say to any program that's exercising people, they should do the right test, make sure you do a test that's not so vigorous. We have a test we use called the Benson protocol, which starts, instead of at 1.7 miles per hour with a 10% incline, it starts at 1 mile per hour, 0% incline, which is about this. And if you can walk in here, then you can take that test. And if you make it through the first 2 minutes, then it's at 1.6 miles per hour, 0% incline. And if you can make it through 4 minutes, then it's 1.6 miles per hour, 2.5% incline. And now I've seen you exercise for 6 minutes at 3 different intensities, including a little incline, which everybody said, oh, I can't do it. Track down with the slides. If that's what you've done and the limiting factor was shortness of breath and lower extremity fatigue, then you should go to that intensity 100%. Work up to it. Within the first 3 sessions, I want to see you at the same intensity that I tested you at, and then after that, we're going forward. Now, we talk about oxygen use during exercise. Okay, how many people use oxygen? How many people use it only during exercise? Okay, so here's the thing about oxygen. There's a myth about oxygen, which is that people, and it has more to do with COPD patients than IPF patients, but there's a myth that some people think that you're going to somehow poison yourself with oxygen, or that you're going to somehow get oxygen toxicity, or that you're going to take too much oxygen and you're going to stop breathing somehow, okay? It's all both, okay? Or I could say, I can make a political statement now. Wrong. Okay, so the point is, use as much oxygen as it takes to keep you saturated, okay? The way that the oxygen hemoglobin dissociation curve, forget everything I just said, but think about it like this. It's a S-shaped curve, okay? So what that means is that between 100% and 90%, things are about the same, but when you drop below 90, 89, 88, it's like a cliff, right? So this is the stage. So here I am at 100%, right? And imagine it's like Mount Rushmore or something, Grand Canyon. I come to, here, now I'm getting to 90, 88. That first step is a doozy, okay? So for people who say, you know what, you could go to 89 or 88, no, you can't. Because the problem is, and there are people who are going to argue with me, okay? Listen, you're going to go to some people and they're going to say, you know what, this guy doesn't know what he's talking about, or this and that, okay? But the thing is that for me, I want to give you every single tool that you need to achieve the maximum benefit and not get hurt. So, in other words, when you start going downhill, your heart's working harder, right? Your heart has to work harder. The pulmonary artery starts to squeeze, right? So pulmonary hypertension, secondary pulmonary hypertension is often a secondary, side effect of having a lung disease for a long time. So the thing is that if you go down and I have you on, just shout out how much oxygen you're using. How many liters?
5, 10.
2, 4, 5, 3. I'm going to tell you, how many? 4. 2, 3, 4, 5. I'm going to tell you something right here. If that's what you guys are using to exercise, some of you are definitely way under oxygenated. Okay? Because I'll tell you the numbers I use: 8, 10, 15, 25, right? Nobody's got a concentrator that goes to 25, but that's why you need rehab, right? Because you can't possibly do at home what we could do with you in the clinic, and likewise, we don't want you doing that. right? When I have you in my place, what I'm doing, I have your EKG on the board, I'm monitoring your heart rate and rhythm the entire time that you're there. I'm checking your oxygen every 5 minutes, I'm checking your blood pressure every 5 minutes, not just at the beginning and the end, right? Because checking at the beginning and the end is like, well, how does this plane fly? I don't know, we'll take a measurement before we take off, and then we'll take another measurement after we land. Meanwhile, the plane could be like, you know, and that's what the workout could be for you too, right? If we check your vital signs only at the beginning, heart rate, rhythm, blood pressure, you know, we don't know what's happening during the actual workout, right? So it's really important to ask people to check your vital signs during the workout at the peak, because you may be 120 over 80 with rest, and maybe when you exercise you're 220 over 140, and that's not okay. So with the oxygen, okay, you need to, everyone, you know, I think it's really important, everyone should have their own pulse oximeter, okay? The pulse oximeter is going to tell you heart rate, and it's going to tell you oxygen saturation. It's not going to tell you the rhythm, okay? You need an EKG for that. But this is going to tell you, am I getting enough oxygen? And understand that there's a greater difference going from 91% to 88% than there is going from 91 to 100%. You know, and it's the same thing with treadmill. It's like, it's not like each 1% has the same value. It's like, we look at coins, I could give you a quarter, I could give you a dime, this guy could have a quarter and a dime, this guy could have a penny and a nickel. They both have 2 coins, but they have very different values. Same type of thing with the oxygen saturation. So the people that are going to say you could go to 89, you could go to 88, you could go to 87, they're not taking into account the damage that can be done to the heart, to the pulmonary artery, increases your chances of arrhythmia, increases your chance of coronary insufficiency, increases your chance of heart failure on a long-term basis. So use as much oxygen as you need. Now, that brings us to another question. But I only have this concentrator, and this concentrator only goes to, right? So think about this. First of all, when you have a concentrator, they're going to give you numbers that may go from 1 to 5 or 1 to 6. Okay, understand that those are not liters per minute of oxygen. Those are settings. Those are your company's settings. And you have to look at it and say, well, how do I know if I'm okay? Or how do I know how much I need the oximeter, right? So when a pilot flies, okay, you may know about this, but when a pilot flies, they don't rely on what they see because their eyes can play tricks on them. When a scuba diver is underwater, they can't rely on how they feel because, you know, as far as how deep are they, because the body plays tricks on you. And it's the same type of thing with oxygen saturation. So you have to rely on your instruments. The same way that a pilot or a scuba diver relies on their instruments, rely on this, okay? So your doctor may say, hey, you know what? You should be using it on setting 2, but that's based on what we're seeing in the office, right? There's a big difference between sitting here when you're getting checked out versus walking up that hill. So I say turn it up as high as you need to maintain a saturation. I like 93% plus. Okay, now again, that brings us to another dilemma. My tank only lasts for this long. My concentrator only provides this much oxygen. So in those situations, you have to work within your limits. But you know, when you go to rehab, so there's a difference between the portable concentrator that you have and the concentrator that you plug into the wall and the tank of oxygen, right? So the least efficient, the one that's going to give you the least percentage of actual oxygen is going to be that portable concentrator. The next best one is going to be the concentrator that you plug into the wall. And the single best, okay, like the purest cut crack, no, I'm just joking, but the best one is those tanks of oxygen, okay, because that's 100% medical grade oxygen. So if you're on your concentrator, even if it's plugging at 3 liters, right, and I put you on a tank at 3 liters, then by all means, you're going to be much higher saturation on that tank with 3 liters than on your concentrator. So what can we do about that? Continuous versus pulsed, okay? That's another issue. So with the pulsed, what that means, everybody who uses pulse knows it means that it's only going to give you a breath when you breathe in. Similar to a scuba tank, right? If I take a scuba tank and I breathe like this, I'm going to drain that tank very quickly. Same thing with your pulse oxygen. Same thing with your pulsed oxygen concentrator. And the other thing about the pulsed oxygen concentrator, remember what I told you before about this 150 milliliter trachea here, right? If I just go, a lot of people do this, they go, got my oxygen, got my oxygen, got my oxygen. But no, you are not getting your oxygen by doing that. The way that you're getting your oxygen is by going. So make sure when you trigger that, right, that you are taking a deep breath with each one so that gets into the lungs where you can use it, okay? It takes a lot of concentration. And the things that I'm talking about today, whether it's exercise or nutrition or stress, these things take effort, okay? They take you fighting, they take a concentrated effort. But you know what, if I put you in the middle of a war zone, you better believe you'd expend the effort to make sure you have the right weapons and to stay down or to run. This is a war zone, okay? IPF, you're fighting a war, okay? And this is your army right here. So you have to take this seriously because you know what? No one's coming into your house and doing something to you. It's here, okay? So let's fight it, Bill.
Can we take a 10-minute break?
Yes.
The restrooms are right in front of the, excuse me, right in front of the elevator, the hallway. And let's be back here in 10 minutes. It's now 11:30, so.
11:30. Oh.